everyone, welcome to researchmd.com. We got a great presentation today. We're going to teach you everything about hypernatremia today. We made a presentation about hyponatremia before. Today in 9 minutes, my friends, we want you all the important facts of high sodium. We're going to teach you everything. Okay, again, my name is Pramil, Cheriyath, the Program Director, Internal Medicine Residency, Transitional Residency, and I teach medical students and residents on a regular basis. So let's get into our topic. So hypernatremia, what is the definition? Sodium greater than 145, okay? Incidence, 0.5 to 3.4% in the general population. Pathogenesis could be several. Let's start with the first one, hypernatremia from net water loss. It could be renal water losses, neurogenic or central diabetes insipidus, nephrogenic diabetes insipidus. It could be loop diuretic, osmotic diuresis. It could be non-renal water losses like hypodipsia, unreplaced insensible loss from respiratory system, cutaneous loss like sweating, burns, and you have the gastrointestinal losses, okay? And hypernatremia can also from hypertonic sodium gain. Let's say if you're giving somebody sodium bicarbonate infusion, oral salt intake, seawater ingestion, hypertonic anemia, hypertonic dialysis, and primary hyperaldosteronism can cause all of that. And the other pathogenesis from hypernatremia based on the volume status also. We can have hypovolemic hypernatremia because you can both water and the sodium is lost. So water loss is greater than the loss of sodium and potassium, and the loss of water and salts usually from the kidneys, or it could be from GI tract because of the diarrhea. Now look, then you have the euvolemic hyponatremia. Either could be renal or extra-renal loss of water without any accompanying loss of salt, diabetic insipidus, and then you got hypervolemic hypernatremia. Sodium intake is greater than water, okay? It can be seen accidental salt water ingestion, salt ingestion attempted to suicide, and administration of hypertonic saline or like hemodialysis errors could be the causes of it. Let's look at the symptoms. Acute, like less than 48 hours, patient will be like mental status changes, lethargy, weakness, irritability, seizure, and osmotic damage to the muscle membrane also lead to hypernatremic or rhabdomyolysis. Okay, if it is acute, think about lethargy, weakness, irritability, seizure. If it is chronic, sometimes it could be like asymptomatic because body already tried to adapt for the situation. Less prominent symptoms primarily due to the accumulation of intracellular osmolytes within the central system can include all the above. Other symptoms it could be increased thirst, increased urinary frequency, gastrointestinal losses, and increased, because of the volume expansion, peripheral edema, pulmonary edema. Then you got volume depletion, including postural hypotension, tachycardia, decreased skin turgor, and dry mucous membrane. So how do you diagnose hypernatremia? First, you have to confirm it's a true hypernatremia, right? Your direct measurement with the check with the serum osmolality, that's the first thing you have to do, okay? Then you always check the serum electrolytes, BUN and creatinine, and then you order for urine for spot osmolarity, sodium, creatinine, and potassium. Then always you check for fractional excretion of sodium. Less than 1% usually suggests, we all know that, like volume depletion, okay? So diagnosis again in patient with the volume depletion. If the urine, that's the first thing you have to look at the urine osmolarity, right? If it is greater than 800 milliosmol per kg and the fractional excretion sodium is less than 1%, you can say like pretty much because of the volume depletion and hypernatremia caused by extra renal loss of sodium and water due to GI causes, vomiting, diarrhea, cutaneous loss, sweating and burns, and mechanical ventilation also. Now let's look at if the urine osmolarity is between 300 to 800, okay, and the fractional excretion of sodium varies, hypernatremia may be caused by a renal loss of water due to osmotic diuresis, use of diuretics, and partial diabetes insipidus, okay? So now, patient with let's go into the euvolemic status. If the urine osmolarity is like less than 300 milliosmol, renal water loss is due to diabetes insipidus, and vasopressin, desmopressin challenges is suggested in those patients, okay? When you vasopressin and desmopressin challenge central diabetes insipidus for additional information. If you need, you do the vasopressin and desmopressin challenge. If response to DDAVP testing, central diabetes insipidus indicated, it could be caused by brain injury, surgery, tumor, and infections, okay? If resistant to DDAVP testing, Then you have to, now nephrogenic diabetes is indicated, which could be caused by hypercalcemia, hypokalemia, medications such as lithium. Now let's look at our urine osmolality, say like between 300 and 800 milliosmol per kg. Hyponatremia in the euvolemic status could be partial diabetes insipidus, osmotic diuresis, and primary hypodipsia. Okay, so let's look at now. You looked at the euvolemic status. We looked at the volume depletion, hypovolemic status. Let's look at what happened in the hypervolemic status. You got like usually caused by sodium ingestion. You're giving hypertonic saline or primary aldosteronism. So let's look at our algorithm right here. The first thing, again, check the urine sodium. Check the serum sodium greater than 145. Okay, and make sure it's not like they have checked the serum osmolality, it's not pseudo hypernatremia. Next thing you have to do is like assess the volume status based on the physical examination. You can see urine sodium, osmolarity. Okay, patient with the hypervolemic. Assess for sodium ingestion such as seawater, administer hypertonic saline, and primary aldosteronism. Okay, let's say the serum sodium is greater than 145. You assess the volume status, then you found if the patient is euvolemic or hypovolemic, and then you look at if urine osmolarity is greater than 800 and the FeNA is less than 1%, you have to assess for extrarenal losses of salt and water, GI loss, vomiting, diarrhea, cutaneous loss of sweating. Now, the urine osmolality is between 300 and 800 milligram, assess for extrarenal loss of salts and water, inadequate water intake, osmotic diuresis, and use of diuretic. Okay. Then you have urine osmolality less than 300 milliosmol per kg, such as renal water loss due to DI and diabetic insipidus, and do water deprivation test and DDAVAP challenge. Is there a response? If there's a response, and then based on it could be central diabetes or nephrogenic diabetes. Okay, so treatment. How do you treat hypernatremia? So chronic hypernatremia, right? Hypovolemic patients should be treated with isotonic saline until vital signs are normal. Once the patient is euvolemic, you calculate the water deficit and calculate the ongoing water loss. Goal of the treatment to lower the serum sodium by 8 to 10 millimole per day for chronic hyponatremia. Don't jump in and correct it so fast. Consequences are high. Let's say if it is hypernatremia, you correct the sodium by like 1 mmol per liter for the first 6 to 8 hours. If it is an acute situation, okay, the way you approach it, the chronic and the acute is different. Remember that. And in the patient with hypovolemia, you have to correct with isotonic saline and underline the volume depletion to be corrected. 5% dextrose in water, hypotonic saline, IV to correct water deficit should be used. Okay. In the patient with the euvolemic hyponatremia, in addition to D5 water to correct with and replace water losses, for patient with the central diabetes insipidus, you can administer DDAVP, which is a synthetic analog of ADH and a longer half-life, administer IV, or you can do subcutaneous or intranasally. For patient with a nephrogenic diabetic insipidus, you can do make sure to stop the causative mechanism fast, and then amiloride may be used for lithium-associated nephrogenic diabetes insipidus. So, in patient with a hypervolemic hyponatremia, you discontinue the salt intake, D5W to correct the water deficit, and you can administer diuretics also. So the treatment is different for if it is hypovolemia, if it is euvolemia, and hypervolemia. Just go through all of those scenarios very carefully, okay? Thank you so much for watching. We'll be back with another presentation. Please subscribe to our channel and please hit the like button. Thank you.